Okay, good morning. I think we rescheduled the meeting from 12 to 11 and bit of a delay, like some technical problems. Jonathan is off sick today, so that is the main problem. So welcome, and I'm going to discuss some brief things of lung cancer screening program, which will be very important for respiratory trainees and all if they are here. So if we talk about lung cancer, that is one of the very important topics which is discussed in world format as well as in national format. Even if it is not discussed frequently, if you know the statistics and all, it is one of the most important things that we have to look in Sri Lankan population too. So if you check the epidemiology and all, this is one of the main cancers worldwide. And as shown here, large number of lung cancer cases diagnosed per year, each and every year, and the numbers are increasing in some of the countries, including Sri Lanka. And this is worldwide, this is one of the number one causes of cancer-related deaths in most of the countries. So that is why this is very important. Touch කරනවා ඉස්සරහට යන්න මේ. So overall in most of the countries, almost all countries, the incidence is much more higher in males than in females. And there's some strong association with smoking, that is tobacco use. But currently the trend in females are increasing, especially in Asian region, which they are doing a lot of research in other countries to find out the cause for this rise in trend in females, especially in non-smoking females in a young age presenting with late stage of lung cancer. So survival wise, again, 5-year survival rate globally, if you take like the global number, it is less compared to other main cancers like colorectal cancer, breast cancer, thyroid cancer and all. Overall survival rate is very low compared to other cancers. If it is diagnosed at earlier stage, they have proven that in a lot of trials, they have proven that the survival is much more better. And there's a lot of regional disparities in this cancer. If you take Western countries, starting with USA, Canada, North American countries, and then UK and then Europe, they have free access to the screening programs and in Asian countries, especially the South Asia, Southeast Asia, and Sri Lanka like countries, there are problems in early diagnosis because we don't have a national program as such to detect these early stage cancers. So if we talk about an objective of a screening program, the main objective is to find these lesions at an earlier stage, which will eventually improve the resectability and the overall survival. And especially the countries like in Sri Lanka, the late stage diagnosis lead into various problems like the survival rates will be low. And then when the patient comes to us, they come in stage 4, and then most of them won't survive more than 6 months. And again, for the palliative treatment and all, and then they have to, the government has to spend a lot of money. Most of the, I mean, almost all the countries in Europe, as well as the countries in North America, especially Canada and USA, they have started a screening program some time back. And as I mentioned, in Sri Lankan setup, we do see a lot of cancer patients, and being the only thoracic surgical center in the country, almost all the patients except the private referrals, they end up in here, the cancer patients. What we see here at National Hospital of Respiratory Diseases is that even the resectable cancers that we see, most of them are in stage 3. Very rarely we get patients with stage 1 and stage 2 disease. And most of the patients we operate are stage 4, either palliative lung resections or some palliative pleural disease, rigid bronchoscopy stenting procedures for stage 4 disease. That is the Sri Lankan statistics which we're going to discuss later in the slides and all. Briefly, that is the situation in Sri Lanka currently with regard to the referrals that we get. And as I said earlier, the early detection, there are several studies shown that the early detection improves the survival. These studies have done some time back, not like last year or 2 years before, some time back in one of the main studies done in North America, the one is in Europe, NLST study and the Nelson study, which you can go through, especially the trainees. One of the key trials that they have done mainly, which shows that the early detection, early lung cancer detection improves the survival of these patients. Subsequently, the other countries like UK, they have conducted their own studies. And then Europe, especially the countries like Italy, France, Germany, they have conducted their own studies. And then all the studies have proven that early cancer detection improves the survival. Then when the early cancer detection is there, that can reduce the burden on the health system itself, because like they are going to spend a lot of monies on palliative care, which will be reduced, especially like oncological treatment and all. Now the recommendations are there, which is led by the WHO and then IARC and National Cancer Control Programs in all over the world to implement this lung cancer screening program in those countries as well as globally. And again, screening now even in UK and Europe, they are aligning with this thing with the tobacco use, and they are implementing these laws and all. In some countries, they have gone to the state that they are banning the tobacco use in those countries. And even in UK, they have given a target population that after that year, they are not going to say that person can't go to a shop and get cigarettes or smoking related products from the shop. It is going to implement even in UK, where a lot of people are smoking. But fortunately, in our country, there are a lot of laws governing in Sri Lanka, where the smoking is prohibited in the public places and all. Compared to like 10 years ago, the smoking incidents and everything is like coming down. But still, we are seeing a lot of patients with lung cancers related to smoking. And again, like these screening programs need a lot of infrastructure development and a lot of training, as well as the facilities to be improved in the surgical sector as well as diagnostic sector. And there should be collaboration with the teams, especially the respiratory teams and the surgical teams, because like if you detect some nodule or some early lung cancer, then there should be pathways developed to direct these patients for the treatment options. So like in UK, there are well-established systems. What they have is like cervical cancer screening programs and breast cancer screening programs. In the given age group, the patient will get a appointment from the regional, their general practitioner, and then they visit the nearest their respiratory center, get down that relevant investigation, and when they have like some findings, and they refer to a cancer pathway, and those patients are operated within 2 to 6 weeks duration, or either diagnostic procedure is done within that given time period, which is called cancer breach dates. And again, there are multidisciplinary team meetings, specially designed to discuss the lung cancer, which we have in our country at NHSL and here at Welisara. And they have like their regional MDTs, especially at the centers where the respiratory teams are available. So moving forward, you can see like there are criteria laid by the WHO for a screening program. Whatever the screening program, like prostate cancer screening, lung cancer screening, breast cancer screening, or cervical cancer screening. These are the WHO recommended criteria. If you are going to implement a screening program nationwide, what are the factors, or what are the things should be fulfilled to start a program? So as you can see, like it should be now in Sri Lanka, the lung cancer is the second most commonest cancer which is prevalent in male population. So the first one is oral cancers, followed by this lung cancer. Sometimes people don't know that. So lung cancer is the second most common killer in males with regard to cancer deaths. And in females, it is within first number 10. But the national data shows that it is becoming more prevalent, especially in young females. So again, then according to WHO criteria, it should be cost effective. And there are several studies done in Sri Lanka to show that early detection will improve the cost effectiveness rather than treating these patients at the palliative setup, because government is spending a lot of money for the oncological treatment. And in UK, they have, like, if you go through the internet and all, there are a separate lung cancer screening program. They have started in 2023, and then now since 2024, they are doing very good lung cancer screening program in UK, and they have their own screening. Before the screening, they had their own research, and some of the units they have developed risk stratification models, which is a new thing, which is not even developed at the earlier stage at Northern American centers. This is based at Liverpool and Manchester, as well as Southampton centers. They have developed this PLCOM 2012, some risk model stratification. So they take patients and then put into this model and detect some patients whose they are going to do the screening and all, which is running in UK currently. And as I mentioned earlier, there are landmark trials in this field of lung cancer screening, Nelson trial and all. And this is freely available in the internet, and you can go through the whole study. This clearly showed that there's a mortality reduction of 26% in men and up to 39% in females, which is very important. And it's clearly stated there's a benefit in doing early stage lung cancer screening, finding out early stage lung cancer by these screening programs. And again, further moving towards, these are the data with regard to this Nelson and UKLS trials, which they have showed that the low dose CT is the standard investigation of choice to detect this early stage lung cancer, not the X-ray. Because even in Sri Lankan setup, we have checked even in the private sector, it is freely available, and the amount of money a person had to spend would be like around 18,000 to maybe 25,000 rupees, even if they do it in the private sector. Most of the district general hospitals and teaching hospitals are having this CT scan facilities. So it is easily can be implemented in Sri Lankan setup. Even in the private sector, it is readily available. And now, overall, now there are a lot of studies, if you check in the internet and all, thinking about Nelson's trial and then NLSC trial, the overall finding, the take-home message is low dose CT scan is a safe, non-invasive, and effective investigation where we can detect early stage lung cancer. And again, the targeted screening is conducted in other countries, especially in UK, USA, and then UK and Canada, like countries, even in Europe. They have given an age range in between 55 to 80 in some other countries, 55 to 75 in other countries and all. So given a target age group, and again, with a history of smoking and all, they do this low dose CT on this given population and detect these early stage lung cancers. And they have developed the cancer treatment pathways, and they have found again, like in most of the units in UK, they are conducting this nowadays, and then they do lung resection in very early stages. This is the UK guidance, which says 55 to 74 years of age, current smokers, those who quit even within last 15 years of age, and the pack years they have given as equal or more than 30 pack years. And again, in UK, they are used this risk stratification models. Again, UK guidance, the follow-up, they have given various follow-up strategies that is depending on the findings they see. Now, when we do a CT, in a patient without any further history, like just only age group and then history of smoking, there may be ground glass opacities we see, there may be subsolid nodules or maybe solid nodules. So depending on that, the decision might be varies, but this is just like a basic guidance, what they do. So depending on the density, volume, and history of the patient, we have to do the follow-up. And in some patients, we have to do the biopsy and go along the surgical pathway. Now, here it shows us some rough guidance on what to do when we found nodule. This is basically what we have put here is the solid nodules. When we do CT, especially in a patient who had a history of smoking and then exposure to industrial smoke and all, you will see a lot of findings on the CT scan. This is purely about the solid lung nodules, and depending on the volume and then the maximum diameter, a group of patients should go under annual follow-up, and some of the patients, like a nodule size of 5 to 8 millimeters, the follow-up is much, we have to do follow-up more frequently. And roughly saying, if it is more than 8 millimeters, it is and if it is suspicious lesion and all, then we have to do a biopsy or surgical resection, maybe frozen section followed by lung resection if it is proven to be a malignancy. So these are rough guidance, but if you go through, like, there are a lot of guidance with regard to the how to manage the ground glass nodules, how to manage the subsolid nodules, and how to manage the solid nodules. So these are rough guidance that they use in the UK setup. And this is again the Sri Lankan system. What we are seeing with the given data, like in 2021, there were 2091 new cases diagnosed. And out of that, in 2019, 1,460 deaths. So sometimes we were amazed when we do this follow-up study, retrospective study, that a lot of patients were diagnosed at the late stage in Sri Lankan setup. And like here, Samir, if you can brief like some, no, Samir is the one who has done the study and all, like he has found the data and all. If you can brief some of the data that we found, specific things like with regard to the region of the country, our Sri Lankan regions and all. I think
so in the sense, this study is not yet published. We are on the verge of getting the ERC. I mean, the proposal is in the ERC. We submitted to the PGIM ERC because these are all data from National Cancer Registry. So I just put from a single year, 2021, 2019. So we are doing a retrospective cumulative statistical analysis for the last 10 years. So in the sense, starting, I mean, we can't do a screening program haphazardly. It has to be a program. Otherwise, it is not going to continue in this country. So for that, we don't have to invent questionnaires, how to do, what to do, because all the system is validated. There are validated questionnaires. There are validated, system, what to do with the LDCT findings and all. What we have to show to the country or to the ministry is that we have a problem with lung cancer. So that is why we are doing this systematic, retrospective, cumulative statistical analysis. So if we go back to the previous slide, you can see, I mean, I just put single year data because we didn't publish it properly. So 2021, we had around 2,000 cases. So if we compare to the deaths, so 75% of the patient who diagnosed with cancer actually died because of the cancer. And our thoracic surgical center, I mean, this is the only center which was severely, in the sense, we only did 200 cases. From that 2,000 cases, that is 10%, severely underutilized. So that means there is some problem. I mean, we are trying to show that we have a problem in Sri Lanka. That is one thing. So if we go into, these are just, male, the second commonest is lung, female that year, the 10th. But if we compare, so in 2018, 2021, so it came up to 8th, it came up to 6th even. So, so this is what you can see is the age-related cancer incidence. So if we go towards around more than 55 years, you can see there is a high spiking rise in the male population. Again, compatible with the Nelson or the UK or the NLSC style. And the next one to your right is from the data from 2005 to 2021 age standardized incidence. So you can see if we compare 2005, it was 7.7. This is per 100,000 population age standardized. So without thinking about the age, so they standardized it. And if we come up to 2021, the 7.7 came up to 13.6. It's more or less double. So that means we have a problem in Sri Lanka, lung cancer. And then we have to show to the ministry or to the authorities that doing this screening program will reduce the economical burden to this country. So that is the next thing. Otherwise, we can do all these LDCTs to all the patients and do everything. So that is the next objective. So,
So that incidence increase. Repeat increasing respiratory centers.
yes, sir.
Increasing
Yes.
detection. The true incidence may be still higher than this.
Yes, sir.
Maybe we are detecting more.
Yes, yes,
Yes.
that is one of the reasons
Yes.
always.
So this first, sir.
Then the age,
Yes, sir.
should we redefine our target group? We don't have that kind of a smoking population
Yes.
comparable to Western countries. Although we have smokers, we don't smoke that much of
Yes, sir.
numbers.
Yeah.
So we may have to redefine.
Yeah, that.
Our criteria.
That might,
Humans are okay.
yeah,
Yes.
but like, with the, number of resections, now he said like clearly, now we do yearly sometimes more than 3,000, 3,500 cases among 4 surgeons in this center. Out of that, maybe 70 to 80% cases are related to cancer. But the number 200 says that is a curative lung resection, which we did. Because sometimes we do like stage 3B disease, stage 4 disease, that may be palliative lung resections. So what we are saying is out of those large numbers, still we have done only 200 cases, which is in the early stage. All the other cases we present late. Secondly, for the thing that you have said, sir, like, with the given data and incidents as well as the finding that we have our surgical resection data and all, because we have followed up that, the age group is far, I mean, yes, we have to redefine, but it is much more like same the Western setup. It is 55 to 75 age group. But having said that, in females, there's a different story. So in females, we have seen even recently for the last 2 years and all, they are presenting with very late stage, but younger patients. That is seen in the Asian continent. Even now, there are a lot of studies going on the Asian continent. Even the Western people are doing those researchers to find out why this is happening in female gender in an early stage. And they present sometimes with the cervical lymph node as well as some other place lymph node, and then we do the biopsy and it is primaries from the lung, which is already stage 4. So what they say is like for the males and females, with the given data, this is the age group, which is compatible roughly with our surgical data. What we do here, if we are going to implement, we can somewhat apply that age group. But yes, as you said, we might have to redefine the age that what we are going to do the screening. But I personally, I don't think it can't be like 30s. It should be around like in between 40 to 70 like.
Exposure like exposure, the occupation.
Yeah, occupation wise, like now, then we will show it later that we have already, there are some data sheets that we have formulated and all. This is like the data for the past 5-6 years that we gathered from here and the national data and all. With regard to the industrial exposure, compared to the Western countries, we see relatively less number of patients having lung cancer related to the industrial exposure. The patients presenting here. The reason is like probably because like in UK we are seeing this with the industrial revolution and all, and then those patients are at the age of like now 70, 80. But in Sri Lanka, we didn't have that such a industrial revolution and all, but still there are a group of people who are presenting with industrial exposure. The problem with that group is like sometimes we do the X-ray CT and all, and then they have some other pathologies like some lung parenchymal diseases, which can give rise to cancers, long-standing lung parenchymal diseases. Yes, definitely we have to redefine the age and all, but up to now, the data that we have analyzed, the data we have, the surgical resection data, and then cancer incident data reported we got from the cancer registry and all, the age group is much more similar. But female, there's a different story. That is, young age group is there, but still the studies are going on for the female group.
Let's not data happening like uniformly from Bangalore also.
Yeah.
They started this lung cancer.
Yeah, that's the thing. Like now, the data is coming from mainly from the Cancer Institute Maharagama, and whatever the lung resection data we are doing here will be going there. So, but fortunately, I mean, there are no other thoracic surgical centers doing lung cancer resection as a program in the country. And there may be some patients which is not reporting to the Cancer Institute Maharagama, which is managed at the regional center, especially stage 4 disease, palliative treatment and all. So I hope if it is
Wait participants,
definitely that data should go to the cancer registry. But sometimes we are missing some patients. But if you are missing those patients, I think that is definitely more than stage 3, stage 3B or stage 4 disease. Because early disease, definitely they will end up in here. And even if they survive with stage 4 with pleural effusion over the bronchial obstruction and all, definitely they will send here. So I think there are part missing data is there. But again, that is the patients who are at very late stage, like stage 4, stage 3B. That's what I thought. And again, like the other interesting finding, what we found is like in Poronnaru area, you can see that the highest crude incident. Crude incident data with the given data setup is seen at Poronnaru and Matara. No?
Yeah, Matara.
Second
For females.
For females, it's Matara. The overall data is coming from Poronnaru.
So what our objective is to first find out there is a problem. So of course, yes, data shows there is a problem. So for implement a program, then we have to say that this is the economical burden will reduce. I'll show that slide later. Then rather than showing the data, we have to do some pilot study to identify that this is important or this is a proper screening program. For that only we got these numbers. So this is just a single year, but I have the total number. So with the proper publication, we can publish the data also. So this is crude rate. That means incidence per 100,000. So if we Polonnaruwa is the highest for the male, 25. But I mean, compare the population to Colombo. The Colombo is 10.
Colombo.
So 10 in the sense, so 10 to 100,000. So it's a proper urban center to conduct a pilot study. The Colombo is a proper urban center because we have so many numbers, although the crude rate is 10. But Polonnaruwa, we might get more patients because of the high crude rate. Even same as in Matara for females. So we have to identify. So that is another objective in this study, where to conduct this study. So for the moment, this is just a statistical analysis. So we are doing it as a surgical team. But for the next step, I think we need mainly the respiratory team, the physicians everywhere in the country to get this data, oncology teams and the radiologists. So we have to all come to a discussion before going on to the step 2. So this is just the beginning.
And
so
again, as you said,
reporting bias from Corona.
Yeah,
Might
maybe,
be,
maybe.
yes.
And again, smoking, like we think that like number of cells from the cigarettes are going down, and then you have to spend like a lot of money if you are going to take one packet of cigarette. But like problem is like recently there was a report, Mahiyangana area, per day the BD 16,500 something sold in the Mahiyangana area only per day. What is that provincial region, a region per day 16,500 sell and all BD vitara. So that is not counted now because sometimes they are locally produced, but it's not coming to the national data saying that. So then we will think, okay, smoking is going down. And in this Polonnaru area, we found that there's one cohort with 200, one patient came with late stage 4 disease, and we got the history and all, and he's a fisherman at Min area, this reservoir. So then we got the history, and he said like 250 odd fishermen are working in that same region. And the main thing that they are using is BD, not the cigarette. So apparently, I think they are using, I think 30, 40, sometimes some people are using 100 per day. So which are missing from the national data. And he came in stage 4 disease.
And so this is the
Hello.
economical burden. In the
Hello.
sense, this is one of our papers, this data. They put it in US dollars because they published it, I think I can remember correctly, DMJ. So Dr. Nuraj Joseph conducted this study with his team, with administrative, and like it's a huge team. So this was done in 2014, which was published in 2017. So this is before all this inflation and everything happens. So this is what they say, 9.1 million, if I'm correct. 9.8 million direct economical burden because we cannot do, surgeries for early stage. And indirect burden, which was calculated with the government accountant and all, because of the patients, they lost and they can't do their job and all. So 121 totals around, indirect one is around 22.3 for the lung cancers.
This is the only study we found related to Sri Lanka done by Nuraj Joseph, if I'm correct.
Yes.
And Nuraj has done this study with the Sri Lankan data, and then he put this US dollar things because like he won't publish this thing, and it's already published in one of the international journals. And this is the only data we found that with regard to Sri Lanka statistics, and he clearly shows, and then his data again clearly shows the operative interventions that we have done is mainly for stage 3 and stage 4. Most of the patients are stage 4, either palliative lung resections, rigid bronchoscopies, or pleuritis. Other group is stage 3. And out of that, we all know that stage 3A is the one that we can do, and stage 3B is, even if we do surgery, I mean, like gain survival rates is very low. And stage 1 and 2, very less number. And he had a very good, I think you can access that paper in the internet, which is clearly showing the economical burden for the country. And the service what we are doing is like more towards the late stages.
So during the COVID period, actually ministry did a audit and all for COVID, cost of managing a COVID patient. So in one of that document, they mentioned that just a HRCT, it is not a low dose, even HRCT cost around 6,500 rupees. So compared to this and an LDCT, so there will be a drastic difference. We are talking about US dollar million, then we are LD, just an HRCT, 6,500 rupees. This is without reporting and all this, just the logistics.
It is done in the government sector.
Government sector.
Are there separate machines for kind of?
No. We can do the same machine. Just only I think if Sumudhu madam is here, Madam Nane.
What's proportionality from a normal class?
So they say, sir, so they are telling about comparing 10 chest sections.
The radiation.
Radiation dose.
Yeah. But because chest X-ray is out of the question, because you can't diagnose any damn thing in chest X-ray. CT is must. So low dose CT is the standard thing which is used in all over the world. And in the private sector, of course, I think the maximum will be like 25,000. Maximum, I'm saying. But in government sector, even if you implement, as he said, it will be much more less because like other factors will be included in the private sector. So HRCT is the option, no other way.
There is concentrated effort on this now, involving the private party. We do this private public mix.
Yes.
It's a WHO concept.
Yes.
Like right now, you won't see, following me, I don't see much of an activities from our college even for lung cancer.
Yes, so that's why we don't have an initiative. So
that's
that
the
is
problem.
why,
And then
so
data was not there.
Data was not there. So that is
Yeah,
what
that's the main
we are
problem.
doing at the moment. So we are the objectives we are fulfilling. So we are showing that there is a problem. We are showing that there is an economical problem, and we are showing that we can solve it, cheaper with the screening for much more cheaper. So we have to publish that, and then the next step will be we have to come together all the colleges, the ministry, the community community physicians, and then come to a discussion, and that is the next part.
In the UK setup, what they do is they have now they have the designated criteria of the age group, and from their GP they have sent a letter to the designated person to come for a one-stop clinic. But in our setup, what I think the most practical way is like we have a lot of respiratory centers throughout the country. So if any person, now if the people in the country, they are knowledgeable about this thing and all, if they come to our clinics, now currently I told Iddagoda sir several times, and then we are in the process of like implementing this thing and all. Any patient comes to my clinic or our clinics, if they are worried, for the past few months, I have done even some of my friends, they came and got down the same CT and all in the private sector, because like they want to know, because they are smokers and all, they are knowledgeable now. So we can do give this service through our respiratory clinics. Because it is all over the spread all over the country, rather than like because we might not be able to do the similar thing like in other countries.
You can say equal to smoking, that kind of concept the public is having.
Yeah.
That has to be taken.
Yes, because nowadays like the data like there should be a separate like studies to be done in the countries like our setup, because some of the patients that we operate, we can't find out what is the reason, even the genetic basis and all, because like there's now a lot of talking about this transboundary air pollution, which is coming on and off like seasonal air pollution in because of the other countries. That is one thing. Second thing, like we have like a lot of smoke related things like at our household, like this mosquito coils and then hadunguru. We don't know the effects of that. So it is not directly related to the smoking. Some people might think, okay, I'm not a smoker and then I won't get it. But this other air pollution factor comes into role in, especially in country like Sri Lanka, this transboundary air pollution, and then the things what we use in household, like hadunguru, the incentive sticks as well as mosquito coils and all. That is a very big problem, I think, in our country, and there should be a proper study to be done, because like that is the main factor. And then again, if people are using rather than the gas cookers, again, that is a exposure passive smoking like a thing. So that we have to analyze.
Once everything agrees on that, in some of the we have identified certain districts where deciding, the district where they reach a blown out. Scan which are amount of bad.
Oh, yeah, like if you call in 10 minutes, what about let's check in one minute.
I think this NHRD, because we have numbers, so although we have a low food rate, the numbers are there. Yes.
Yeah, so
this will be the.
So I think the best option is like the Western province is the one that we had, like, because the largest number of patients and all. But like with the given data, Polonnaru and Matra might be good areas to explore. But Western province is the one where we have like a lot of numbers. So yeah. Surgical clinics we have already, I think, started, like I told Iddagoda sir several times ago, even to Jiva sir, even Dr. Asnayaga knows about it. And then any patient who's willing to come and can I check this, then we can offer that service in surgical clinic. What I want to say is like the take home message, like it is very common now. Lung cancer is very common and it is underreported, as now we have discussed. And then sometimes we are not, even the lung cancer program is not getting the proper number because of these very late presentations. And they are not reported to the main central database. And this is a killer. And then still the world, and we don't know what is the reason for these young females are getting this. What their hypothesis is something related to the genetic, something related to the genetic basis, like females are getting stage 4 lung disease at very early stages. Like even in Sri Lanka, I have seen for the past 6 months, maybe 5 or 6 patients in their 30s. That is a very big problem, because like most of them have very small kids and all. And then there are separate studies done in international setup in UK and Europe, the economic burden and then burden to the family, whether there's any gender disparity. So it has clearly shown in the European and international studies, when the lung cancer is for a female, that affect more to the society, family, and to the economy of the country rather than male is getting it. They have shown it clearly. There are a lot of studies. So that's why what we said, like now to have a specification, now these studies, if you go through, NS study and Nelson trial was done in long time back. I can't remember, I think 5 to 8 years ago. And then they have like stayed in USA is one of the countries they have started early. UK started when we do foreign training, there was no screening program. But now they have a screening program, but those days they were doing these trials.
As you said, the setup is there.
Yes.
There's a GP system.
Yes, we don't have it.
The GP system is set. If you are a smoker,
Yes.
over 50 to 74 years, you have a 30-pack year history of smoking. You are given a date for a low dose CT.
Yes.
Come and get it done. And
Yes.
if it is, if a nodule is detected, they will follow up that
Yes.
nodule. I have seen a lot of patients who have undergone curative resections.
Yes.
And they are living for 20, 30, 40 years.
Yes,
after
yes, yes.
So, and there's a clear cost benefit as well, but as Sir said, our problem here is we don't have a good GP system
Yes.
here to help that sort of a setup. But as you said, we can use the respiratory clinics.
Yeah, I think that is the only way forward because like,
But again, the problem here would be who should we be screening for? Because our smoking rates are not very high.
Yeah.
Are we targeting the smoking population?
no, I think like we have to check the age. ඒකට තමයි we have to, because we have like, yeah, because now if we try to start a pilot program and define our age group, that will be a long process. But like Europe, UK and US and North American countries have given clearly the age group and all. There's a difference between 5 years and all, but otherwise there's a main group, which is the patterns are similar in Sri Lankan setup. Our pattern and then the age group is similar in the international setup. Yes, we can't catch these early stage lung cancers in females. That is a separate problem. But I think at the end of this year, probably next year, there will be a lot of results are coming. And there will be some some investigations rather than low dose CT that we can implement in the population setup. Because in UK, I personally know some of the studies are going on. Try to find some like with the inhaled, exhaled air, find out whether they can detect the cancer. There are separate studies going in Cambridge as well as in Oxford to find out some other ways rather than going for a CT. So definitely there will be something coming up in the end of this year, maybe next year. With the exhaled breath, they can find out the cancer cells, early stages.
It's actually we can give a good date in with the data that we are analyzing currently over the 10 years. To analyze data was showing not 55 years, but 61 to 75 plus. So
60 plus
from
75.
that, we can actually come up to a decision in the sense, not, I mean, not from the data per se, with the data, and we can have a discussion with all the relevant physicians and surgeons and radiologists, but what to otherwise we have to do a study to come to a age level that will take so many years and all. So rather
This is just like a format that we have in our surgical clinics. Personally, I use this thing as a like, we can't like ask 100 questions and all to standardize the method and all. This is the thing which I have formulated already. I have shared it with Iddagoda sir and our team. So you said, so this is like a format that what we do. Very simple, like single format, single paper, and then patient comes, do this thing, do the CT and findings, then patient go in the surgical pathway or follow-up pathway.
Can get help from Stanford Cancer.
Yeah.
one actually, so
There's a
the analysis is actually done from the community, I mean, 2 person from the community physicians, I mean, they are colleagues. So they are communicating with the cancer control program, otherwise we cannot, I cannot get data from there. So anyway, so they are involved. So this preliminary data has to be published, then I think we can have a.
because now more just they have a program for this that's news and
Yes.
And the other thing is like if anybody, especially the respiratory trainees are interested in, now this is the main idea of putting this lecture because like there are a lot of research and then studies can be done in this area, which is not done for the past like 10-15 years. There are some papers from our center, from other centers and all, but still a lot to be done. And for the trainees, there's a very good topic for this thing, I think. And then I have personally checked with the WHO and UN. They have a lot of money for the programs like this. Because preventive programs, they are willing to spend money. But the problem is like, we have to do a proposal and then, there should be a pathway. And if it is going through a college or an association, that will be much more easier rather than doing it by a single person. So lot can be done. and then we can save a lot of lives. That is what my personal feeling. Even the stage 3A disease, which is resectable, we do the surgery. I rarely see, I think for the past, since my SR period, for the past more than 5 years, I have seen only 2 patients. After lung cancer resection, I have seen maybe 2 patients with this stage 3 disease. And the other countries are moving rapidly forward. Like even the stage 1A, 1B, they resect, stage 2A, they resect, stage 3B, they give neoadjuvant immunotherapy. 2B to 3A, they give neoadjuvant immunotherapy, then do the surgery. So then now they have found that from stage 2B to 3A, rather than going surgery straight away, if we can give neoadjuvant immunotherapy, then do surgery, their survival rate is much more higher than doing surgery and then do the oncological treatment. That is the practice since last year in UK. But we don't have immunotherapy available and all, and at least if we can find these patients early, stage 1 or 2 disease, I think that is better. I don't know when we can get the immunotherapy freely available for our patients, I don't know. But still, I know that Nuraj has a very good program. They are at Matra, I think. He has a very good program. He gave this for the patients this immunotherapy and all. But the problem is we can't refer from each and everybody to Matra. Only that region we can refer. That is the problem. Yeah. Okay, I think that is it. And if you have any problem, I think the time is running out already 12.
I don't see much of a, as I said earlier, lung cancer awareness program is kind of thing on lung cancer day. No, since Welisara is NHRD is the main center for treatment. Can we start this as well with the college and the clinical threat together?
Giving sessions,
and the other thing is, even next year, college president
Yeah.
is going to be a surgeon.
Yeah.
And the thing is now, on this particular lung cancer day, particular as the World Lung Cancer Day, and we start the media and everything from here.
Yeah, that's true.
We can get
Yeah.
the people like Nurad.
Yes.
To speak what his experience and the college.
Yeah.
And the surgeons here. And clinical society together.
Yes,
And our media and everything to make an awareness on this.
And again, like this is the presentation and the data, whatever the studies we have done, Samira, and then this all the data we have found is not like for the past 2 months. No, when I was SR in 2017 and all, I started this formulating this database and all. Now it is like anybody who's interested in having a lung cancer database, we can give even a soft copy format, which you can put into a tab and then enter the data. So now it is running. So the past 5, 6, 7 years, we have been gathering data and all. And this was like Samira has done this for the past 6 months and all, and then he was gathering data and then got these results. So this is not just only a like for the past few months. No, for years we have been trying to find out this thing. Then as a SR, I couldn't present these things, and then COVID came and all, and then a lot of issues going there. But now, like that is the time. So that's why like we presenting this data and all for the for everybody to see, and then we can do something. Whatever, if anybody is interested, feel free to come and ask from Samira or myself, and we can give even the data sheets and the soft copy format of the data entry forms. So you can do it by your like tab and all. Whatever the study you do, even a medical officer, which will contribute this national program. Maybe we don't know. Maybe in 5 years, 10 years, somebody will come and present very good presentation here. I don't know with the data.
You're not too far away. World Lung Cancer Day is August 1st.
Yes. Okay. Awesome.
Female, young females lung cancer problem, we can.
No, we can't. No, that is the thing. Yes, that is clearly said. Yeah, lung cancer screening is not related to this female issue. Like there are a lot of studies going in USA, Europe, and UK with regard to this. Why these females, young females, getting this late stages lung cancer? But for some reason that is seen in Asian countries, mainly Southeast Asia, South Asia, China, and all this our region. So the problem is like in this region, the China, Japan, South Korea, Korean countries, they are doing a lot of research. But in India, Sri Lanka, Bangladesh, Pakistan, we are doing a lot of patients. We are seeing a lot of patients, but we are not doing any significant research. So what they are saying is the hypothesis is there is something related to the sex chromosomes and genomes and some environmental factor affecting more on the females rather than in males. And recently in Cambridge University or Oxford, they have found that some how air pollutants, a new pathway, how they can create lung cancer without any genetic underlying mutation. So I can't remember the exact details and all. Less than some amount of micro particles, they go and stimulate a particular receptors in the cells in the lung, and they can start some de novo cancer pathway from the air pollutants itself. No history, nothing. So maybe now their hypothesis is that air pollutants and something in the environment is stimulating females more than the males. That's why they are getting that. So, but still it's not proven. It's not proven.
It means a more stimulable than
Yeah. so that may be the reason. Okay. Yeah, mainly the adeno. And lot of studies going on in mainly in the yes, not in the clinical setup, but in the research setup, molecular level, there are a lot of studies going on. Especially in there's some cancer center in Italy, like world program. They are doing a lot of research on this this subject. Italy or France, if I'm correct.
That we have seen 80% like 60 patients for our now in the around 80% they have found up at the stage 4. And the delay is mostly like hospital delay also. First initial symptoms to like diagnosis, it took like 32 days. Because of
yeah, so like that is very correct, because in UK the cancer breach date is 28 days or 30 days. Some centers it is 6 weeks, but in our center I have to say like all the 4 surgeons, our cancer breach dates are less than 4 weeks, and I think Sujir sir and Handra sir will agree with me. I think it is less than 2 weeks. For me, I think for three of us, Dr. Asnagi is not here. It is less than 2 weeks. That is 14 days for our cancer breach date. That is, if a patient refers to us, if it is even not diagnosed of, if it's not biopsy proven, if it is radiologically proven as a cancer, 4 surgeons here, they operate more than 95-98% of the time. That patient is operated within 2 weeks, which is very much better than the Western status, because their one is 28 days. Some centers 4 weeks or 6 weeks, because they don't have their time and all. But this is our status. Again, that is we found this thing with our data and all. But the problem is we don't get the early stage lung cancers. That's the problem. We do some palliative resection for stage 4 hemoptysis. We don't have any other option. And then I have personally, sometimes I got like recently referred some patients from NHS. Because like in Sri Lankan setup, it is very complicated. You know, patient is having TB, maybe some sarcoidosis, some intestinal lung disease and all, and there's a lesion. And followed up that lesion for like 6 months, 8 months, and then maybe biopsy done, discussing the MDT and all. But then finally found that there's a cancer focus. And when we go in and try to do the resection, it is basically a palliative resection with all the lymph nodal metastasis and all. And then like there were 2 or 3 patients sent from the NHS. But I'm not saying like not purposefully delayed, but then because of the other underlying condition in Sri Lankan setup, it tend to get delayed, because like previous history of TB, there's a scarring of the lung, and then we don't think this can become a cancer. So there are like several patients, but in UK, like TB prevalence is less, rather than in some areas in London and Manchester, maybe areas in Southampton. But then when they see a lesion, that is more suggestive of a cancer, and then they investigate or maybe take it out. But in our setup, we can't do like resection and biopsy in all the TB patients who's having lung lesions. But for us, it will be very challenging, especially for respiratory vision, even for the surgeons. It will be very challenging in Sri Lankan setup to find out what are the lesions that we should biopsy or do the surgery. That is a problem in our setup. Even the lymph node now, sometimes we get like cancers early stage, and then there are nodes and having a previous history of TB. So there may be some lymph node stations with, you know, some fibros and all, and we can't find out. Even if you do a PET CT, it's very difficult to say whether this is spread of the cancer and all, and we have to operate even with the N2 lung disease. Because we don't know, even we do the biopsy, it doesn't come, because like previous TB and then fibros node. But still, we have operated on a patient with N2 disease, which will be prognosis is bad. Yes, indeed, it will be very difficult in Sri Lankan setup because of TB and other diseases. Topical problem, yeah.
Last week, myself and Rasnaik, we got this
Yeah.
they talk about treating stage 1 lung cancer. So we are mainly for now. However, gold standard it used to be 10 years ago lobectomy. Now they're focused on segmentectomy.
Yes,
Technology
yes.
also developed to find what
Yes.
segment is involved.
That is because like 1A disease,
Market.
the study proven is, as I said, if you do a segmentectomy proper, that's it. 1A disease.
The whole idea of doing
That's it.
screening to
Then,
get the
yes,
stage 1.
1A disease you can do. And the thing is like in North American setup in USA, they are offering surgery for small cell lung cancer, which is diagnosed at stage 1A and do the resection. We never do surgery because there's no point of doing surgery for small cell lung cancer. But in USA, highly specific centers like Sloan Kettering Cancer Center and all, because I know that some of the surgeons I work with, they have been working there. So they do operate on very early stage small cell lung cancer with good outcome, then do surgery. And then now the trials and everything is moving towards that. If you detect a lung cancer with some nodes, better to give neoadjuvant chemotherapy when the cancer is there and when the nodes is there. Because then that will initiate some immunoresponse from the body itself to kill the micro cells in the circulation. The patient will not get metastasis after surgery. That is the basis of neoadjuvant immunotherapy in this setup. Earlier, what it said is like we have to remove the nodes and everything and then cancer with the cancer. But now they say keep the cancer, keep the nodes, give the neoadjuvant, then it will go and target, and body itself will create some immune response which is much more better than the chemotherapy. When the circulating some micro cancer cells is there, it will destroy by the body itself. That is the recent data what they show. But I don't think within the next 5 to 10 years we won't be able to go to that level. I don't know.
Very costly.
Very costly. Neoadjuvant immunotherapy, but Nuraj is doing a great job. However, he has found the funds and all, and he's doing a very great job. Yes, so yeah, they do segment because they found it earlier stages. But yeah, yes. Because like what we do is like sometimes we see like 2 centimeters, then we have to do a lobectomy. If it's like very early stage, like 1 centimeter, we can escape with a 0.8 lung nodule, biopsy, and then segmentectomy is enough. Yeah, no? Yes, and it's time is passing, and thank you very much. And we had a good discussion. Anybody who's interested, especially the trainees, want to get the data and all, especially the forms and all, can meet Samir and then get the data.
So thank Saman Iddagoda, our assistant surgeon, for his wonderful lecture on lung cancer screening, and Samir, our senior registrar as well, for his very good tips. And also thank you very much.